Buenas tardes.
Good afternoon. Once again, we welcome all participants to this panel on healthcare to the immigrant community and its impact during the COVID-19 pandemic. We are all living through the ravages of the pandemic and the resulting recession, and we ask ourselves, why are some racial and ethnic minority groups disproportionately affected by COVID-19? In summary, let's look at what the Center for Disease Control and Prevention (CDC) of the US Department of Health and Human Services says about it. In their report titled Considerations on Health Equity and Racial and Ethnic Minority Groups, updated on April 19, 2021, they state the COVID-19 pandemic exposed social and racial injustices and inequalities in terms of public health. It has made it clear that equity in access to healthcare remains a reality as COVID-19 affected many racial and ethnic minority groups differently, placing them at greater risk of getting sick and dying. According to the report, some of the factors that affect equality in access to healthcare are discrimination. Unfortunately, insistence which purpose is to protect well-being or health, there is discrimination. Discrimination which includes racism can lead to chronic and toxic stress and leads to the social and economic factors that increase the risk of COVID-19 for some people from racial and ethnic minority groups. Barriers to access healthcare services. Problems such as lack of insurance coverage, transportation, childcare services, or the inability to take days off at work can make it difficult to attend medical appointments. Cultural differences between patients and providers, as well as language barriers. Neighborhood and physical environment. This study found that geographic areas with more significant social and economic inequalities had higher proportions of Hispanic and non-white residents, people working in manual, essential, and public-facing sectors, more overcrowded housing, and food and healthcare insecurity. Therefore, they may be more likely to be exposed to COVID-19. Occupation. Racial and ethnic minority groups are disproportionately represented in virtual work environments such as health centers, farms, factories, warehouses, food processing, food shelter and services, retail services, grocery stores, and public transport. Below, we welcome you, the expert panelists who will be sharing with us their knowledge and opinions on this vital topic, which will be moderated by Dr. Yeseli de la Cruz, Executive Director of the Latino Action Network Foundation.
Well, thank you everyone for joining us for our healthcare among immigrant community and its impact during the COVID-19 pandemic. My name is Dr. Yeseli de la Cruz. I'm a licensed clinical social worker and I serve as Executive Director for the Latino Action Network Foundation. I'll be serving as today's moderator. I've posed a few questions to our panelists and we'll be generating some dialogue from those questions. Before we get started, I'd like to provide a brief introduction just to frame today's discussion. Latinos make up 21% of New Jersey's population of 8.9 million, according to 2016 estimates of the US Census Bureau. With the foreign-born representing 42% of the Latino population, the majority of Latino families are mixed status families, and most commonly with US-born children and one or more parent that is undocumented. Undocumented immigrants, for multiple reasons, were at risk for societal isolation and mental health concerns prior to the COVID-19 pandemic. In 2009, the CDC produced a report highlighting the increased risk to the health of undocumented immigrants in a pandemic due to their likelihood to live in more crowded housing situations and the pre-existing structural and cross-cultural barriers to accessing care. In addition, Latino immigrants are uniquely affected economically, as evidenced by their representation in low-wage essential worker employment, such as the food industry, grocery stores, etc. And if unemployed, do not qualify for financial relief efforts. So therefore, the current situation serves to compound an already dire situation for these individuals. So just thinking in regards to the last year and all the work that we've been seeing at the front lines of the pandemic and working with Latino immigrants, I'd like to open the floor to Clarice Bustamante. Oh, no, actually, I'm gonna open the floor to Amanda Medina Forrester. I'm sorry, I'm sorry for confusing that. But Amanda Medina Forrester is the Executive Director of the Office of Minority and Multicultural Health. They serve to promote health equity for all and reduce health disparities. And Amanda, I'm gonna pose the first question to you. Can you speak to some current trends in Latino health and mental health during the pandemic? Information we have at the state level.
Oh, thank you so much, Dr. De La Cruz. And I'm really privileged and honored to be here with you and Ms. Bustamante. I think this is a great experience just to have you guys part of this, and me being part of this space is, I'm very honored that you guys brought us on. In regards to the Department of New Jersey of Health, we've been very busy before COVID. In regards to health disparities, we got to see many, many disparities across the most vulnerable populations, marginalized populations, and Latinos are one of the top ones that, you know, they came in with higher comorbidities, diabetes, chronic diseases, cancer, and of course, other mental health. But now we added COVID to the mix. And so at this time, I would like to talk about the COVID impact of many of our people of color. Including, of course, Latinos, but also our African Americans, our Blacks, and other disparate populations. So just to give everybody a level set of what's happened, as of March 31st, we had over 800,000 cases of confirmed cases of COVID in New Jersey. That's 800,000 cases. Because of these, 22,000 people died because of COVID. That's one of the highest rates of the United States of deaths. But when you start to look at it more carefully, look at the health disparities, you start to see the differences in race and ethnicity among these groups. For cases, for instance, our partners, our Blacks of New Jersey, are 17% higher counts of cases than the white counterparts. For Hispanics, it's 68% higher than whites. So let's think about that. What is happening to our people of color right now because of COVID? And also just to note, when you look at the Asian population, Hispanics are 85% higher of COVID cases compared to the Asian counterparts. So again, what is happening to our Hispanics? Why are they most impacted by COVID? Hospitalizations. Just what COVID has done to us for hospitalizations. Blacks are 2.5 times higher than whites to be hospitalized. Latinos are 2.8 times higher than whites to be hospitalized. So again, it's not just being infected by the virus. This is actually affecting our hospitalizations. Then we go on to deaths. So this is where we also see some striking differences. Latinos are 2 times more likely to die from COVID than the whites. Now that, again, when you start to break it down by age and by gender, we start to see males, Latino males, have the highest COVID deaths across the state when you do age-adjusted rates. So there's entirety generations of Latino men being wiped out because of this pandemic. You know, and as it is, they came in, they already had so many comorbidities, so many other conditions, and now we just had COVID on top of that. So that's basically what we've had. Just to give a little, also some sense of the COVID disparities of the vaccine, we have about 4.6 million people have been vaccinated. And from that 4.6, 3.2 are fully vaccinated. That means they got the 2 doses, right? So it's the 2-dose vaccine journey. However, so that's about 21% of New Jerseyans that have been vaccinated. However, Latinos lag. We only have 13% of Latinos that are currently vaccinated. Again, so you look at those who are dying, who are most impacted, and they're the least to get vaccinated. So there's many, many, many discussions, many strategies, many partnerships happening right now to ensure that we try to get our people of color, specifically Latinos, vaccinated and tested for COVID. So I kind of hope that answered your question, Dr. De La Cruz, or just the level set of New Jersey.
It did. That's great information. And those numbers are, very important for us to know in terms of thinking about future and the solutions. So I'd actually like to pose the next question to Clarice Bustamante. Clarice is manager clinical of the community outreach program at St. Joseph's Health. So she has spent her life in personal career experiences to help herself, her patients, and community members overcome the challenges of accessing health-related education and resources that support health prevention and management of the disease. So, Clarice, I'd actually like to give you the floor to share a little bit more about yourself. And I'm going to pose the next question also to you. What are the current system barriers to acquiring quality care for Latino immigrants from your perspective?
Thank you for inviting me, having me this panel. And I want to start, if I want to talk about myself, I'm a first generation immigrant. I came to the United States and I face all the challenge that every immigrant faces. There are many resources, but the problem is that we don't know about the resources. So we learn as we fall, and health prevention is a major issue. And we know that before the COVID pandemic, and that made the COVID-19 now, it made it worse among the most vulnerable populations. So I work at St. Mary's Hospital for 10 years, and I left St. Mary's when they closed because they have financial issues. And then I moved to long-term, I did home care, I did nursing instruction, and came back to St. Joe's Health. Why? Because at St. Joe's, I felt I could do a little bit more, being a first generation immigrant, and I want to help a little bit more. And that's why I'm a nurse, and right now I'm working as a clinical community outreach. So why I'm here? Working at St. Joe's Hospital, working at St. Mary's, I realized that both organizations were a non-for-profit organizations, and these organizations, like especially St. Joe's now, is an academic organization, the New Jersey, New York metropolitan area that is sponsored by the founders, the Sisters of Charity of St. Elizabeth's. In 1867, we started with 12 beds, and now we have over 1,000 beds. So the mission of St. Joe's is to take care of everyone, regardless any difference. So we're talking about race, socioeconomic, any type of difference. So the services are designed to heal not only the body, but also the mind, the body, and the spirit. And we all work as a team in an environment and a culture of caring, and the patient is always first. So we are proud. We are over 5,000 employees, and we are also diverse. We have a big diversity at St. Joe's. At St. Joe's, during the COVID, I have data that we provide interpretation to 95 different languages. So we are ready to take care of patients with different language. And when we cannot find translation, we bring in person people to help them. The other thing is that St. Joe's Hospital is a system. So we have St. Joe's Hospital Medical Center in Patterson. We have the Children's Hospital. We are Trauma Center. We are stroke certified. And then we have in Wayne, we are stroke certified. We also have a rehab long-term care in Cedar Grove. We have visiting nurses in Torwa, and we have over 30 different satellites to take care of the populations. We are the #2 busiest ED in the country. And we are the 3rd busiest ED in New Jersey. So that that tells us a lot, and then when I look over here, what is going on? So then I look over here, according with the data USA in 2018, in Passaic County, New Jersey, we had like 500,000 people. But the problem is that we have 2,697 people living per square mile. So if we talk about COVID, so density is a major issue, not only among Hispanic, but among the whole population. 43% were Hispanic, 40% white, and 10% Black American. The income per capita was 34,000, which was less than the United States rates. Males, that's a big problem. They make 1.38 times the highest salary when compared with women, so puts women at disadvantage. We have 13.4% people that live below poverty level, 13.4 below poverty level. In New Jersey, the education is tied with the economy, the education is tied with the income, right? So then we have the 85.4% less, compared with the New Jersey rate. So we have only 85.4 people that attend, school, some type of, graduating from school. Bachelor's degree, we only have people, only 1 of 3 people have bachelor's degree, which is like 2/3 less than when we compare this data with the state of New Jersey. We have foreign born, 34%. So that means that 1 of 3 are now, all American, born in the United States. So what happened in Patterson, working in Patterson, having our main hospital in Patterson? When I talk about Patterson, we include Passaic because Passaic now, they go to us, and then especially for the services that the smaller hospitals don't have. So in Patterson alone, we have approximately 150 residents, and we have 52 different ethnic groups. So that's a challenge. So we have a language other than English is spoken in homes. The percentage is 61% of the population speaks other language than English at home, only in Paris. So based on the CDC 2020 in New Jersey, in the census 2019, in New Jersey, we had 20.9% of the population were Hispanic. So 1 of 5 are Hispanic, right? In New Jersey. But more than 30% of this population that are Hispanic were infected with the COVID. And 1 of 3 of Hispanic that had the infection died because of the COVID-19. The other thing that also affected Hispanic was that Hispanic between age 25 and 49 years of age were affected disproportionately when an increased number of hospitalizations and deaths. And that includes our own staff. We have our staff members, young male, Hispanic, that die with the COVID. And aside from that, we had to take care of also other problems that we usually have to take care of business every day. So based on the census, of the 2017, when we look at the demographic profile of the Hispanics, it showed that 19.4% of Hispanics were living in poverty, right? 1 of 3 students graduate from high school. 1 of 5 don't have health insurance. So we have an increase in employment. Most of our Hispanic population, they work in services. Only few have management positions because the education, they don't have much resources of opportunities. The built environment, so then where they live, where are the houses? So that prevents outdoor activities, that prevents access to healthy foods. We don't have big supermarkets in those areas. That prevents medical attention due to lack of access. But when we talk about access or cost, we have to take into consideration that even though St. Joe's has charity care that we tell everybody, we do not refuse care to anyone, sometimes they don't come. Why? They only go to the ED because they have to skip a day from work and they need that money to pay the rent or put one food, on the table. So those are major issues. So for us, our communities are very greatly affected by homelessness. We have Eva's Village, where they house a big population that take care of homelessness and also substance abuse, issues. Opium, we have an epidemic here in Passaic County. We also have other problems like, age. We have homebound people that live in homes. We have minorities, undocumented. We have non-English speaking, not only Spanish. We have, I'm telling you, we're interpreting for 95 different languages. We have no insurance or low insurance. Medicaid itself, sometimes it causes issues because there are not many doctors that take those insurance. There are not many services that will provide because they have this Medicaid or Medicare because the payment is different. So as St. Joe's, we provide interpretations. And then I want to tell you, how do we respond now? Like when we talk about how do we respond to the pandemic, aside from all the problems that we had before. So we joined, our CEO, Kevin Slavin, he joined the governor's pandemic response. So we all know that joining that pandemic response, it was a lot, maybe, how can we say, easier to respond because we had to face not enough ventilators, not enough personal protective equipment, not enough resources that we needed because we were not prepared. We learned that we didn't have public health to respond to this, pandemic. So then at the same time that in New Jersey, the governor, and throughout New Jersey, we opened like testing centers. St. Joe's also opened its own with our lab. Our own lab helped the implementation of a testing center. So what happened with us then? So every day we leave this, every day more patients fill every bed. Every bed was filled. All the treatments, all the procedure areas. We work over capacity. St. Joseph's added 150 beds, critical care unit, expanded negative pressure rooms, because that's to prevent, to contain the virus, to try to get it through a filter, to a HEPA filter, so it will not go to the other areas. We had innovative ways. The EMTs created shields that protect them from getting infected. The IV lines, we extended them so that way we can see the patients through the window. And then we had telehealth, we have computer, we have put them on the phone to talk with family members. But despite that, on April 15, St. Joe's had a peak of 456 COVID patients. And what I'm telling you is, like, when we experience this, now it's so easy to say that when we were experiencing that. So then we were supposed to house 456 patients, and most of the patients had to go to critical care compared, with pre-COVID. So then how did we do that? Our front line was tired, was exhausted. We didn't have enough human resources anymore. It was a tremendous deployment. So then everyone that was clinical was deployed. Like me, I'm a community outreach, clinical community outreach. We opened Barnett Hospital in Patterson to house the patients that we didn't have no more beds. So to house these extra patients, the overflows in Barnett Hospital. So I was deployed there and I had to act as an educator. I trained 66 nurses, agency nurses that didn't have any knowledge about St. Joe's to take care of patients, but we did it. We had nurses from other states that came to help us. St. Joe's, as an organization, as a resource, also, we thought about our staff because our staff was experiencing the same issues, the community, they're the community. So we provided housing to them because a lot of us were afraid to go home and give the COVID to one of our loved ones. So we provide hotel for our staff, we provide housing, we provide meals, access to meals at different times. We provide wellness, child care, and a lot of our patients, as I say, they were in critical care, and some of them, they didn't go home. Some of them, they died. So then what are we going to do? Now that we learned that we had more death people that, than World War I, Korean.
So Clarice, I'm so sorry to stop you, Clarice, but I just want to open the floor a little bit for some more discussion. Because what I'm thinking about in terms of, just to create some more collaborative discussion, what I'm hearing is that, more and more the impact of COVID on the Latino community is really about these social determinants of health, right? That we're talking about: housing, socioeconomic status, ability to take off from work, the ability to social distance, all these access to healthcare. So that I wanted to actually ask Amanda, from a statewide lens, what have been some lessons learned? And are there some ways that these things will provide possibly a blueprint to the future to address health equity? I don't know if that sounds too convoluted, but at any way that you could answer that, we'd appreciate it.
Yeah, thank you, Dr. De La Cruz. So I could give it two ways. I could talk about what we've done and what lessons we learned from what we've done, because I think that sets the pathway for moving forward. So as you know, when the pandemic started, we all of us were in shock. We didn't know how to respond. Nobody knew about the virus. We were turning a lot to our European counterparts on what they were doing. And so they were 2 weeks ahead of us all the time. So we watched them very closely. What are they doing? How are they doing it? And what as a state? New Jersey is very unique because of the densely populated communities, just like Ms. Bustamante said. It's very different from, say, Texas, say, California. We're very, very densely populated, which is why we're probably one of the first states that got most impacted. But the one thing, because of our governor and because of our commissioner of health, Judy Priscilli, we wanted to ensure that equitable access across everything we did was at the forefront. Through testing, through hospitalizations, through ventilators, through vaccinations. From day one, they established a pandemic team of experts across the state, brought these experts together, and just like Ms. Bustamante said, St. Joe's was a part of that pandemic team, and they started to really move fast on what to do. So again, we were very, very privileged to be in New Jersey because we had these experts already in the field working with us. So immediately started to identify these high-risk populations. Who is the most affected right away? Looking at data, very, very minute data, every hour, by the hour. And then we started to prioritize. So once we started to get some trends, we started to prioritize these populations for testing and the vaccination. For instance, people experiencing homelessness, incredibly vulnerable because they congregate together, they live together, they transport together. I mean, and this is very much like the migrant seasonal farm workers. When we had the pandemic in March, we were starting to get the incoming migrant seasonal farm workers in South Jersey. And so we had to get ready for that. We were expecting about 10,000 migrant seasonal farm workers coming up from the Carolinas and Florida. And of course, they work together, they live together, just everything's congregate, and they were going to catch the COVID like wildfire. So we had to work very quickly with these vulnerable populations. So that's how we first did. We did the prioritization of vulnerable populations, and then we had to move in really quickly. One piece too that was a great lesson learned was working closely with our stakeholders. We needed to get them immediately in the picture. with our local public health departments, our federally qualified health centers. They were essential from day one. Our hospitals, our other state agencies, such as the Department of Human Services, the Office of New Americans. So all these amazing state agencies had to come together quickly as well. We also identified municipalities that were most heavily impacted by COVID, looking at race and ethnicity and COVID burden and other social determinants of health. This is called the CDC Social Vulnerability Index. So the CDC SVI is what we looked at closely to look at these municipalities across the state and what we needed to do some deep dive micro planning for these municipalities. Of course, we wanted to ensure that these municipalities had everything they needed, and they told us what they needed. It wasn't the state running it. It was definitely this local public health departments, the local municipalities, the local officials, them telling us, this is what we need help. And us looking at their data, yes, let's help you. So the partnership was incredibly lesson learned from day one. We also had to ensure that the testing and the vaccination sites that we had were definitely scheduled. We're scheduling and registering people who had no barriers. We want to make sure all populations, regardless of immigration status, had access to this. No cost, no documentation required, no immigrant status required. Like, we want to make this as easy as possible. We got criticized from other states about this, but we were dead serious that this is equitable. We need to make sure everybody had equal opportunity to get the vaccine and get a test and get hospitalization and get care. And of course, like I said, immigration status, no documentation, you're fine. You still get tested, you still get the vaccine for free. Of course, also the public charge. You remember that? That was really hard for many of our undocumented residents here. And so the fear of the public charge and how that's going to affect their status was something that we had to deal with early on. So we worked very closely with Massachusetts, Connecticut, and other sister states to get this public charge removed from the COVID pandemic experience, such as healthcare. You seek healthcare, you seek vaccination, and you seek testing, it should not affect your public charge case at all. So those are the big pieces that we've done for lessons learned. For the go ahead. Sorry.
So sorry, I was just thinking, this is my mind. I think this is amazing that, I think the pandemic offered us an opportunity to do these things that we had been fighting for so long, increasing access to care. So I'm really curious in regards to this public charge, if the governor will and the state and our community stakeholders and partners, if we'll continue to be able to think about ways to increasing and continuing that access despite the pandemic, right? And regardless of any issue, because, as we know, how one of the biggest healthcare disparities is access, right? And health coverage, and for those who are undocumented. So I think it'd be very interesting if we can do it for the pandemic, how we can do it long-term and as a permanent solution, as opposed to just a response in crisis. But I'd actually like to open up the floor to Glorice again, just to create some back and forth dialogue and really think about what, if from your first, it sounds like we're doing everything to increase the access, but for some reason the Latino community is still lagging in vaccinations and still more likely to contract COVID. So what are we missing? Even if we have everything, what are the barriers for Latinos to actually get the care that they need right now during the pandemic? What have you been seeing on the ground?
What I see in the Latinos, like I say, now we see that we have resources to vaccinate, we have resources to test. The problem is that, like we mentioned before, like the social determinants of health, because and also the distrust that we have among our community. our community like the cost, like, yes, we have this for free. Now I'm giving you that in your language. Now you understand. Now I'm taking your hand because that's what I do. I give them, say, call me. I can make your appointment. But then they don't call me. And I ask, what happened? You didn't call me. I had to work. I'm sorry, I cannot. But for that, what we are doing is that now we will open 7 days a week. Now we open Saturday and Sundays. Now we are opening like evening hours, like for the children. We are opening also, so we are doing that. Now, it is hard to combat that distrust because yes, we are only targeting, like for us as an organization, we only targeting that specific population, right? So it's a small population there. So I believe that what we are doing at the municipality level, at the county level, like there has to be somehow of disseminating that information that this work, and then we should apply this to other communities that face the same issues, that have the same challenge. Because I believe for us, it's working. We provided 80,000 vaccines, only St. Joe's alone. And now we are vaccinating 12 to 15, and we are getting people calling us. We are going to churches. We went to Eva's shelter. We vaccinated them there. So like we went to them. So we are going to the worship places. We are communicating. We have a committee that is interfaith leaders. So we advise and we told them, take a picture. Take a picture that you are getting the vaccine. So that way it will help. They trust you. And then that way it will help for the rest to follow you and get these vaccines. So those are the things that we are doing. We are trying to be out. So not only inside now, every patient that comes to the emergency room, if they are eligible, we vaccinate them. Every patient that it is a clinic patient also is getting the vaccine. Now we are also homebound patients. So we have another team that is the EMTs. They're going home, they're vaccinating our patients. So we are doing a lot of things. We restructure, but what I'm thinking is we are doing all of this, like, you know, we are sharing resources. We are partnering, we are collaborating. And I hope so, we continue doing this. If we continue doing this, I believe there will be a change. I believe there will be.
Thank you so much, Claudice, for your feedback and your insights on that. So I'm going to pose the next question to Amanda. Any thoughts, anything left you'd like to share in regards to the pandemic and healthcare access in Latinos?
No, I think Claudice said it perfectly. I think it's us going to the people. Before we were very spoiled. We had people wanting the vaccine, right? So it was the very low supply with a high demand. Now it's split. Now we have a lot of vaccine, but we don't have the demand. And it's exactly what Claudice said. It's us going to the people, and across the state, we have so many clinics that it's at faith-based organizations, community-based organizations. It's outreach. We have a whole team of outreach workers. Like it's really driving boots on the ground. Exactly what Claudice said. These are the remedies to get us through this major hump of the pandemic.
Okay. So, I mean, my last question is something we hadn't quite addressed, and Claudice and Amanda, at any point in time, you can share your thoughts about this. But what are some legislative and policy efforts that are on the table right now that maybe we can start sharing with people that would increase care beyond the pandemic and beyond? So any thoughts?
So I could share a little bit of what the state's always talking about is funding opportunities. The one thing that the CDC, the Center for Disease Control and Prevention, they are funding many organizations and many opportunities for small community-based organizations, for small faith-based organizations to really help them as like a restart and also serve their communities. That's something we're seeing at the federal level. At the state level, my office of Minority and Multicultural Health, we are changing our grant system to give to small community-based organizations because of the pandemic effect of these small communities, and I think that's where we're going to start to see a lot of new initiatives in regards to people who have been mostly affected by COVID. How can we help them? How can we restart their economy, their social determinants of health? It's not just the health, it's everything that was impacted, the housing, childcare, employment. So much has impacted our people of color, especially Latinos. And I think you're going to start to see a lot of social determinants of health assistance coming our way.
And I want to add that, those policies and new policies that are ongoing, they support equity. Because, and I try to explain to, to some people, and I say, it's not equality we're looking for, because if you provide the vaccine in every place the same way, those that are vulnerable, those that need, the extra resources are not going to get that. So equity is targeting those populations that are the most vulnerable, going to them, helping them, so we can raise them at the same level of the rest. And that's the only way that we can really learn, and support an infrastructure where we support the most vulnerable, we get them out at the same level, and then we can say we are promoting, equity and equality.
Yeah, I think, from the Latino Action Network Foundation's perspective also, some things that I'm thinking current legislations is, and policy efforts are, covering actually all kids, right? Including children who are undocumented. Just because so often we only provide access to one portion of care, right? Emergency care. But very, very rarely we're thinking about all that's needed in terms of holistic care, right? Prescription medication, access, all those kinds of things, even specialized healthcare treatment. And all these, we really, I think that with the pandemic, we want to think health, but I think we have to think more social. And that's the piece that I think really requires us to have a long-standing change. So while we want to think health, we might also need to start thinking about housing and what that means. It sounds like we also need to think about economic status, socioeconomic status, and actually how to address poverty in New Jersey. I'm sorry. So just to address those kind of things, I think that while we want to address health, we actually might have to more likely address systems, so that we can actually provide people equitable care. Again, we're all working from home, so you're hearing somebody ringing my bell. Any last thoughts?
I think one other piece that just to bring up to this group is the systemic racism that we have seen decades and decades, and what we are seeing in healthcare settings and any type of care settings, and not just in healthcare. I'm just saying in general, the systemic racism. That's something that the Department of Health had been looking at prior to COVID, and now we're seeing it more pronounced here. And that's, when I'm thinking of, Dr. De La Cruz, the legislative and policy pieces, I think, as a state, we're moving towards implicit, explicit bias remedies, policies for all people. Because again, what has happened the past 4 years with our federal administration has left a mark. And so now we need to really work with our constituents and work with our policies and our legislators that what can we do for many, many vulnerable populations.
Yes, I want to add, and I say yes, that systemic racism, have existed throughout, since the beginning of the earth. And the thing is that it is so hard because it's embedded. And even myself, I consider myself, I'm Hispanic, and I grew up in a generation where it's systemic, it is ingrained in everybody's mind. So for that, I believe there should be a type, like if we want to combat that, it's like we say policies, but also fostering education. Because the more information, the more informed, the more people that learns, and is aware that diversity is like for us, is like for a lot of people, it's a challenge, but for others, is being diverse, you learn from each other. and you become stronger and you learn from each other and you can share more resources. So there has to be some type of policy that supports that thinking. We are like not looking in the bad way, like, you know, oh, the Hispanics are this or Black American are this. Instead, looking at the strengths. What is it good that I have from you to take and pick that and show that and inform people. This is why America is great. America is great because the diversity. So that's what we need to emphasize in education.
Thank you for inviting me, and welcome to all who are attending the YACO conference. I welcome all of you who are attending, and especially our new immigrants, and give a huge thank you to all of you who have been providing essential work throughout the COVID pandemic on the front lines. You've really been able to help us get through this, and you've honestly been on the front line suffering a lot more than many of us have, and so we really wanted to recognize and appreciate all the work that you've done. My name is Mara Udelman. I'm the managing attorney for the National Health Law Program's Washington, D.C. office. If you're not familiar with the National Health Law Program, we are a nonprofit organization that just celebrated our 50th anniversary, and we focus on providing quality and accessible healthcare to low-income and underserved populations. We've been working on immigrant health issues for probably almost our entire period of time. I've been at the National Health Law Program a little over 20 years, and I've been working on improving access to care for immigrants and improving language access for my whole time at the National Health Law Program. So I'm really thrilled to be participating with you today. There's 3 issues that I want to be able to talk with you about. The first is, what were the impacts we saw that the pandemic had on immigrant communities and on limited English proficient or LEP individuals? The second question that I'll answer are, what are some of the remedies that we're going to be looking at in the coming year to help provide more support and assistance to the communities that we serve, and particularly immigrants? And then third, what are some of the resources that are needed to help achieve our goals and what we'll be doing to achieve them? Now, just for a little bit of background, since I work in NHELP's Washington, D.C. office, the DC office really focuses on federal legislative and administrative advocacy. So we'll be looking forward to working with both Congress and the Biden-Harris administration to really look to improve policies and procedures, enact new laws, get more funding, and really look at a range of ways that we can help support the communities that we serve. So in answering the first question, what were the main impacts that the pandemic affected on immigrants and low income and underserved populations? Well, certainly those communities saw a disproportionate number of COVID cases and infections and deaths. It's really hit these communities incredibly hard due to a range of factors. Some of it is a lack of access to health insurance and not being able to get care when people actually get sick, or not being able to get tested. A lot of people in these communities are also frontline and essential workers. They're working in healthcare. They're working on our farms doing farm work. They're working in our factories. They're doing home care for people who have disabilities or are older adults in the community. They're working in nursing homes. They couldn't stay home and telecommute. They had to go out every day and work with the communities, and therefore were at much higher risk of getting infected, especially early on in the pandemic when they may not have had access to protective equipment like masks and gowns and things like that. Another big issue that has contributed to the disproportionate number of cases and deaths is the lack of communication, a lack of effective communication. Many immigrants who might be limited English proficient weren't able to get effective communication and weren't able to get information in their languages that told them how to protect themselves and their families. You know, one of the big issues we saw early on is that hospitals with lots of COVID cases prevented family members and friends from accompanying sick patients. This meant that a patient might be intubated and have no one there to understand what was happening and what was going wrong. And a lot of times those same hospitals weren't communicating effectively with the family members at home. Sometimes language access wasn't even provided, even though it's required under federal law. So a big part of it was just a lack of effective communication. And then certainly we've continued to see a lack of information available in non-English languages. The National Health Law Program actually just recently filed a complaint with the federal Office for Civil Rights at the Department of Health and Human Services, and with the Office for Civil Rights at the Federal Emergency Management Agency, or FEMA. And we documented information in over 20 states where language access wasn't accessible. Many of the state's COVID websites didn't have information in non-English languages, or were only providing information using automated translation software, which has been documented to be incredibly inaccurate, particularly when it comes to complex health information. So when we have over 8% of the population residing in the United States are limited English proficient, and we're not providing effective communication in languages other than English, we're definitely going to see that disproportionate impact on these communities. So what are some of the remedies that we're going to be looking at, and we've been looking at, to try to help revive the people and the communities that we're talking about today? That's the second question that I really want to answer and get at. So one of the big ones is just, how do we improve access to some of the big publicly funded federal health programs? You know, programs like Medicaid and CHIP, where many immigrants are barred for the first 5 years they're in the United States. And then we could talk about the federal marketplaces that were created under the Affordable Care Act, where individuals such as Deferred Action for Childhood Arrivals or our Dreamers can't get financial assistance to buy insurance. So the National Health Hub program is working with a lot of our federal partners, other community-based organizations and advocacy organizations, to push really hard to get some of these burdensome and prohibitive federal policies gotten get rid of them. So we've introduced legislation to get rid of this 5-year bar. There's been legislation also introduced to provide coverage to the Dreamers. We're also looking at ways that we could provide more coverage to undocumented immigrants. All of these are areas where people can get involved and let their members of Congress know that they're interested in seeing this legislation move forward. And I certainly hope that the disproportionate impact we've seen COVID have on immigrants and communities of color will give us more opportunities this year to advance this type of legislation. Another piece that we need to do is, again, address language access. Unfortunately, a lot of times we see language access as an afterthought or not even thought about at all. We need to find ways to make sure that language access is thought of at the beginning. So if you're getting a document from the federal government that's a notice about your rights, taglines that give you a marker that information is available in your language, that should be at the front page of a document. So if you're getting an English notice that's important to you, you should see something in your language right up front that tells you this notice is important. And if you can't read it in English, where do you call to get help? When you're calling a Medicaid agency or a marketplace to get help, you shouldn't have to figure out how to use English voice prompts in order to get through to a call center representative who can connect you with an interpreter. These are also issues that we're trying to think at. We also need to really have a lot more funding for language services. We hear from a lot of healthcare providers and even from state governments that it costs money to do this. It's the law. Let's not forget this. There are many federal civil rights laws that require the provision of language access and effective communication, and say you can't discriminate on the basis of someone's national origin or immigration status. But we still have a really long way to go, and there's a lot that could be done both in Congress and in the Department of Health and Human Services and other agencies to improve language access and improve access to these federally funded health programs, as well as COVID testing and treatment and even vaccinations. And so we really need to focus on this we need to focus on this effective communication, both during COVID while we're still fighting the pandemic and beyond it. We need to make sure that when the government is creating new websites or producing new forms or documents that are going to be used by the public, that those are automatically translated into at least 15 languages. That should just be part of the standard process. And we shouldn't have to continually push and raise these questions saying, when are you going to provide services for non-English speakers? So my third question that I wanted to answer is, what are some of the priorities and resources that we need to achieve these goals, and what are we going to do to seek them? Well, as I said, we filed a complaint with the Office for Civil Rights. So we do hope that there will be a response to that. And again, that brings both a crackdown on those who are violating federal civil rights laws, but it also brings more awareness. I think a lot of organizations don't understand why computer automated translation isn't effective. Only if you've actually looked at some of the ways that this happens and seen that these systems can be 55% wrong in translating languages, do you understand that just because you can put a little widget or a little icon on your website and say, you know, get 100 languages here, why that's not effective. And of course, once a limited English proficient person goes and gets wrong information, they're not going to trust that site again. So we really need to think about education, outreach, funding, and the provision of effective communication language services. So again, there's a lot that the government could do. There's bills that Congress could pass. We did work on a number of them last year that were specific to COVID, that would have focused efforts on translating information into more languages and providing effective oral communication with interpreters. We hope that we might have some additional opportunities this year. There's also administrative activities that this administration can do. Again, they can look at some of the programs that are already in place and remind grantees or remind participants in the programs like healthcare providers or state Medicaid agencies that there's more that they should be doing. And that's, of course, there's also the enforcement provisions. The Office for Civil Rights will investigate complaints filed by individuals or organizations that allege discrimination on the basis of language, as well as race, ethnicity, national origin, sex, disability. And so again, people can file complaints themselves with the Office for Civil Rights, and we hope that this administration will be more committed to doing the enforcement as well. We also want to see collecting better demographic data. You know, it's really hard to identify who's limited English proficient or if there's disparities happening because of race if we don't collect the data to identify people. And so we'd like to see better demographic data collection happen across the federal government. So if you're applying for Medicaid or you're applying for the marketplace, those applications should ask for your race, ethnicity, your language, your sex, your sexual orientation and gender identity, your disability status. It's not trying to get secret information from individuals. It's trying to get the information the government needs to identify if there are health disparities. And then if they see that there are, to figure out what to do to fix them and to prevent them from happening in the future. So I think there's a lot that both the federal government and Congress can do to really address a lot of these situations. Hindsight, of course, is 2020, but we need to prepare for the next issues coming down the pike. And it shouldn't just be in a pandemic when we're thinking about language access or we're thinking about how immigrants and limited English proficient individuals and Black, Indigenous, and people of color are just again being harmed in so many more ways and suffering disproportionately because of the policies of the government and the lack of funding. States and local governments can also do a lot here. Again, there's economies of scale. It's much easier if a bigger entity takes on the task of translating documents than asking every single healthcare provider or every single community clinic to do it. So again, there's really a lot that can be done. We've seen, you know, the impact that COVID has had on immigrants, on our Black and brown communities, on low-income individuals has exacerbated what we've seen as centuries of structural racism in this country. It really just brought it again to the forefront. It's not a secret, but we shouldn't see this repeat time after time after time. We need to be strong, we need to be active, we need to advocate for our rights, and we need to make sure that we're ready both to continue to address the pandemic now and to include and to make really strong forward progress while we have the opportunities as well. So again, I really want to thank all of you for participating in the conference, for inviting me here today, and to really think about ways that you can stand up and help us reiterate the needs of your communities and really work to improve healthcare quality and access for all. If you're interested in checking out our website, it's www.healthlaw.org. We also have a website where we encourage individuals to participate in the advocacy process by submitting their stories and their opinions to the federal government. That website is called Why My Care Counts. And you can look that up on the web as well. It's whymycarecounts.org. And we'll let you know when there are policies being proposed by the federal government that you may want to weigh in on and let them know your opinion. So again, thank you for everything that you've been doing to help us all get through the pandemic. Thank you for attending the conference. And we really look forward to working with all of you to continue to make the forward progress that we haven't seen and we really need to see continue and work to improve our communities and access to healthcare. Thank you.
This is great. These are great points. Thank you, Clarice. Thank you, Amanda, for your thoughts and your insights. So thank you all for joining us, and we'll stop now. Thank you.
Thank you so much.
Agradecemos mucho su participación. Por favor, no olviden completar las encuestas. Recuerden que sus respuestas son absolutamente privadas y no recogeremos ninguna información personal. Sus sugerencias y comentarios nos ayudan a mejorar para futuras ediciones de nuestro evento. Gracias.